From Cinderella specialty to blushing bride. Well, of course, it's the emergency general surgical specialty I'm referring to. To enact change, and the sort of change that we've heard your specialty requires, needs a number of things, and our enthusiasm and time commitment as individuals will not be enough. One requires levers in the first instance, and those levers need to come both from a national level and also to local executive level. And you'd certainly now have for change, you have that lever from your own college, you have the lever from your association, and you also have the department's ear here. They're adamant that change is required, and I think many of you will be starting to see that permeating down through your specialist commissioning groups. So actually, to deliver change, what one will require is to look at the pathway that you intend your patients to follow and to split it up into bite-sized chunks. And amongst that, particularly in this sort of pathway that involves many specialties, it's a very complicated pathway. It will require standards to be set and subsequent audits to be performed and peer review to follow with it. So in terms of moving on, and I'm sorry if I'm going to repeat some of what's gone before, but before you can design your pathway, it's absolutely imperative to understand what's gone wrong with what you've already got, actually. And as many people have mentioned before, looking at the numbers that have come to critical care, there's a really stark lack of use of critical care for this higher risk group of patients. We put through about 100,000 patients annually through the intensive care units in the United Kingdom. Not the high dependency units, we'd put through another 200,000 through those. And of that 100,000, we'll only see about 14% coming through from emergency general surgery. And that population will have a mortality of about 25%, and they will cost about £88 million for their care. And if you look at the older patients, their mortality can approach 50% for many of them, actually. John touched on the knowing the risk, the CPOD report. I'm not going to go through it in the same detail that John did, but I am going to pluck out the bits that are probably relevant to the design of a pathway. This was the largest audit that's ever been done, nearly 20,000 patients. And it's interesting in that the anaesthetists were asked to categorise patients in a number of ways, and you've seen the data. Their categorisation was subsequently looked at by assessors and graded, and their conclusions about the quality of the original assessment is contained within the document. And I think there are a few areas I would take a few exceptions to, but it certainly did look at infrastructure, it looked at process measures, and it looked at outcome, in particular the critical care usage and mortality. So if we just look at the pre-surgery pathway and what did the audit show us? Well, it really did show us that we were pretty poor at actually estimating risk, actually. And for the elective patients, it's much easier, isn't it? Because obviously there are functional tests such as CPET where patients can go and have a dynamic test and have their cardio and pulmonary reserve looked at objectively. For the emergency patients, much harder. And if you actually look at how the anaesthetists categorise the patients, there's a stark difference. Sorry, I'll just go back. Sorry. Now completely. Yes, a stark difference actually in how the assessors categorise the patients as opposed to how the anaesthetists on the shop floor. And I'm not sure whether that reflects their reluctance possibly to categorise people higher because knowing that they maybe hadn't asked for a bed or there wasn't a bed or whatever the infrastructure locally and those issues were. But a real problem there in people assessing risk, actually. And with that, a problem in identifying the acutely ill patient and appropriate resuscitation, and obviously then the time to operate would be prolonged. In the perioperative pathway, I find this even more stark because an awful lot has been published on optimising patients perioperatively in the last 10 years. We've had a huge amount of data published by intensivists and by anaesthetists looking at how best to manage patients. And if you look at the use of invasive monitoring and active optimization, I was absolutely staggered to see that less than a third of the high-risk patients had an arterial line in. You know, and only 14% had a CVP line. How on earth can you optimize in any way your cardiac output if you haven't even got a CVC line? I mean, one would regularly use things like mixed venous saturation as a measure of cardiac output. So, I mean, really that signifies to me very poor understanding of the literature, very poor use of the evidence base. And of course, if you looked at cardiac output, only 5% of them were looking at that. And it's hardly surprising that the incidence of complications perioperatively was 10%. And I'm sure that subsequently would lead into their failure as a team to recognise the true mortality for that population and subsequently determining the right journey for them. If you actually looked at the high risk group, in fact, you were less likely, you were more likely to get worse care if you were an emergency patient than you were as an elective. So, it really does signify that the team haven't really taken on board risk assessment, stratification, optimization, and forward planning, really. In terms of post-operatively, you've seen before the poor use of critical care following surgery. And again, I'm sure that's because people don't accurately understand the risk, actually. And less than 10% of patients access critical care. And there was a greater propensity if you were an elective patient, and I can understand why, looking at it on the shop floor, the way all the levers in the system on the shop floor are geared to elective activity, I can understand entirely why they would have a higher presence, actually. But in fact, if you actually looked at those high-risk patients, only a quarter of them were actually gaining access to critical care. Not surprisingly then, that if you subsequently went back to critical care with organ failure, that in fact your risk of death was higher. If you're an elective patient, it was double. If you're an emergency patient, it was 3 times your risk of death, actually. And one thing to remember, I think that knowing the risk quite nicely identified the real risk of death. If you were a high-risk patient having an immediate surgical procedure, abdominal surgical procedure, then your risk of death is 25%. If you're having an urgent procedure, then it's 12%. So considerably higher than what we would ever accept for our elective population. Ian's touched on this document, and I think now that you have a number of levers from the college and the association pushing forward change, you should grasp those, because that's a real opportunity. And I think if you don't, you will find that it will be done to you, actually. In terms of this document, I co-chaired with Ian, I represented the department for this, and I think for the first time we've actually set a standard for what would be high risk. Now you may disagree, and we're certainly willing to discuss that, but high risk would be an expected hospital mortality of more than 5%, actually, which is considering the elective mortality and the difference. It's maybe not that far off the mark, actually. This document specified a number of things, and I would hope that you would all be able to work towards delivering that, but certainly much greater use of consultants in the decision making and much greater use of critical care. So how would you actually use all that to define your pathway? And what I'm going to describe now is what we've done in Manchester Royal to try and really change the way our pathway works. I'm more than happy to share it with you, because describing your pathway will ultimately then require you to use various tools to ensure that the pathway is reliable. And it's no good just to monitor the end of the pathway. You need to break it up into bite-sized chunks, set standards to that, monitor that, and subsequently undertake some peer review. So in terms of taking it forward, the first thing to do is to define your pathway, very simply here, from start of clinical assessment through to post-operative care. And what we did, and you probably won't be able to read this, but I'm more than happy for people to have the slides, actually. Each of those sections, we set out the features of that section, the decision-making for that section, the interventions that should occur, the standards that should pertain, and the audits that should follow, actually. And you'll see within it, we clearly identified high-risk patients separately. So there's a different journey for the high-risk patients as there is for the compared to the lower-risk patients. And in terms of high risk, how would you define high risk? Well, we've looked at our own data, and for us a mortality of 10% could be categorised with patients who had 2 or more SIRS criteria with at least one organ, acute organ dysfunction. That's not organ failure, but organ dysfunction. Or somebody over the age of 65, someone who's dialysis dependent. We have a lot of dialysis patients in our institution. ASA over 3 plus 1 organ dysfunction, or ASA 4 or 5, or anyone who's immunocompromised or transplant. Again, we have a lot of those patients within our institution. Now, in terms of intraoperative care, it's essential there that the anaesthetists really as a group collectively take the evidence base and design their perioperative fluid management and intervention strategy, including, how are they going to monitor, what are they going to use, how are they going to optimize, what are the drugs they're going to use, etc., etc., etc. And also at the end of surgery to assess with the surgical team what's the risk of mortality. Now, has our original mortality prediction been amended by what we found in surgery? So have we had evidence of fecal soiling? If we have, yes, obviously that would add to your risk of death, and that would take you up, if you weren't already in the higher group, into the higher group, and that patient would then automatically go through to critical care, actually. And I think in terms of defining critical care, people often say, there isn't a bed. To make a change, one has to actually deliver. So a patient's need is different from the resources. One can always deliver if the need is required. You may have to deliver it in an interim strategy in terms of leaving them in recovery or putting the less sick patient from critical care in recovery. But actually not to offer it would be completely wrong, actually. So in terms of redefining your risk at the end, we touched on the surgical findings, but there'll be other things that would push you into a higher risk group. So if your lactate was over 4, for instance, or if you had new organ dysfunction during surgery, which people do develop that, then that they would all constitute higher risk, actually. And we wouldn't want to see any readmissions or any admissions to critical care back within the 48-hour window. So in terms of delivering that pathway, how can you deliver that pathway in a reliable way? Because we can set standards, and we all do in our everyday practice, but how do you actually deliver it? Well, the only way you can actually do that, truthfully, is probably to set a couple of bundles. And those bundles almost become points that you can't pass until each bit of the bundle is complete. So the first bundle would be an admission bundle that would be pre-surgery, and you wouldn't be allowed to enter surgery, for instance, until the bundle was complete and all aspects were signed off. The second bundle could be at the end of surgery, and you weren't allowed to leave theatre until the second bundle. So you have some clear endpoints in your pathway, and you're fortunate in that for this population, the pathway has to include a trip into theatre. So you do have a clear start and end to that perioperative phase, actually. The beauty of the bundle is it does allow you to actually monitor various interventions. So the things we've chosen is time to and use of CT. So we've set ourselves a very tight schedule for abdominal CT for the high-risk patients. The senior involvement in the decision-making, the access to theatre, the intraoperative care variation, and the admission to critical care. And they're all currently being audited as part of our pathway. Now, this is our admission bundle. So this is the bundle that's completed before you go to theatre. So it's done as you come in. So you have the initial referral to surgery. You have the various investigations that need to be done. You have the early management then, and the split into whether you're high risk or not. And MRCS trainee must complete this, and they must sign for it, and they must date and time when the decisions are made. That bundle, this is a sheet that this comes off and goes into the notes, the actual bit in the middle. That goes on the front of the notes, and it means that for audit purposes, the notes can be pulled much easier. And this is the end of surgery bundle, so it's separating out the higher risk patients. For us in the first phase, we've gone for 10% as our admission. All patients with 10%, expected 10% mortality are admitted to critical care. And we've split it up into the findings in surgery and then again into whether you're high risk or not. And that has to be signed by the anaesthetist and by the surgeon as well. And similarly, that goes into the notes, and the blue sticker goes on the front of the notes, actually. So to conclude, I think you have a real opportunity now. You have the levers in the system because you have the sponsorship from the college, from the association, from the Department of Health. The commissioners you've now got their ear. They're interested. They're keen to try and work to deliver a much better outcome for patients. You know, I think really when we look back, not to have made any impact on this in the last 20 years, it's a very sad indictment on where we are, and yet we've made such huge inroads into the rest of our work actually. So you really do have the spotlight on you, and you really have that opportunity for change. In terms of delivering change, I think we need to move down to ensure that we have the sponsorship at the exec level in each of the trusts, because it's those people who need to work with you to actually deliver the change on the shop floor, and you need to work with your colleagues to actually develop a pathway that fits your use, fits your patient population, identifies those higher risk patients, and ensures that the patients can optimise what they need to optimise at the right time. And I would say ignore the Cinderella group at your peril, because someone will come and change it if you don't do it yourself. Thank you very much.